Okay, so welcome everybody. One of the great things of the LSE Health and Social Care seminar series is we have lots of different topics, we end up with lots of different audiences, and there's lots of different people here today, but with lots of expertise, I understand, so it's great to see you here, so thank you very much. Delighted to ask Paul to talk to us. Paul's been with us here at LSE for 4 months, 3 months, 3 or 4 months. This is your third time with us on sabbaticals and so on. We do lots of work with Paul. Paul's going to talk about work which is actually from his home base in Michigan rather than work with us here. And what I suggest we do, we hand over to Paul. Do you have to take comments as you go along, or do you want to hang on till the end?
I'd probably take a couple of questions, and if I know I'll get to it, I can say I'll get to it later in the presentation, but feel free to ask a question.
Okay, so
all right, over to you. Super, great, thank you very much. I appreciate the opportunity to have a chance to share with you some of the work that my colleagues and I are doing in Michigan. I know there's at least one other person in the room from Michigan, but since probably many of you are not, I just wanted to take literally a minute to give a little bit of background about myself and my home base. Michigan State University, where I'm on faculty, is a large public research-oriented university. Got about 47,000 students. At least a quarter of them are international students, with a large number of Asian students. My position is in the School of Social Work, which is a nationally accredited undergraduate and graduate programs, as well as a PhD program, where we prepare faculty for positions in other universities. My roles, academically, I'm a professor and teaching in the school. I'm director of distance education and technology, so most of my work in that capacity has to do with online and blended learning. And I also do research on technology issues related to human services. The Michigan Stroke Transitions Trial, which is the project that I'm talking about today, really involves a team of people, and I want to make sure that I give credit early on to that team. It's a team, by the way, that worked for about 2 years before we submitted the proposal that was funded that I'm going to talk to you about today. And we had 2 earlier submissions that were not funded. And I think it's part of that story, as we all know. You go through, you submit, you change, and you keep trying until you get success. Matt Reeves is our PI, and Matt's actually from the UK. He's our epidemiologist and our stroke expert. My main task has been with the technology-based intervention that I'll be talking about. Ann Hughes has been basically in charge of the case management intervention that's part of the trial. Amanda Woodward's been our outcome and measurement expert. And Michelle Fritz has sort of been running the program as project directors often do. She's our project manager. She does everything. I really wonder if she ever sleeps. And then there are a number of people that I'll talk about at the end, if there's time, it's a cast of hundreds practically. By the way, I do feel slightly anxious because I know many of you from PSSRU just attended yesterday a workshop on skills for presentation. I hope you don't have a checklist to see how well my presentation meets up to those criteria. All right, our agenda. I'm going to talk a little bit about background on strokes and transition. Some people in the audience, I'm guessing, know more about strokes than others. Talk a little bit about PCORI. It is a very unique funding source for this proposal. Talk about the research design, and then present some of the initial focus group data, talk about our website development, our immediate priorities, and there will be plenty of time for questions at the end. I'll be watching the clock and make sure that we allow plenty of time for that. So a couple of stroke statistics. I didn't realize myself until I got involved in this project how common it is. In the UK, 152,000 annual incidents. In the US, about almost 800,000. Okay. Stroke is the 4th largest cause of death in the UK and the 2nd largest cause of death in the world, which was also a bit of a surprise. In the UK, there are about 1.2 million stroke survivors. In the US, there are over 7 million stroke survivors. So we're talking about here as a large population. This is not something particularly, it's not a small sliver for sure. And it is a leading cause of serious long-term disability. That's one of the big problems, right? People come home, and what we find is that stroke is an acute onset, unexpected event. So people are generally not prepared for it. Their support system is not prepared for it. Average time in hospital is very short. About 50% of patients are discharged, these are US data, are discharged home right from hospital. Another 25% spend a short time in a rehab facility and are then discharged home. So we're talking about 75% of those 800,000 people a year who are at home receiving care in the community. There's a wide variation in stroke severity and in pre-stroke function, both of which will impact the cause of treatment and the cause of recovery, the course of recovery, sorry. And the typical stroke recovery period is usually greater than 100 days, and there are people who never fully recover from the stroke. This is a diagram that's going to be hard to see from the back, but it's an episode of stroke care. The main point here, I think, is that we basically here have a population with no preparation for what's going to happen to them next. That their intervention with the system starts with the first onset of symptoms. And you've got acute care, post-acute care, potentially in a rehab setting, and then living in the community, living in long-term care, or some people, unfortunately, pass away. There are a number of challenges that we can identify in hospital-based stroke care. The average length of stay in the U.S. for stroke is 4 days. It does not allow a lot of time. What it means is stroke patients are there and are frequently often still in a state of shock. And there is a post-stroke stress disorder, which I had not heard about that particular acronym before getting involved in this project, that is used to designate the status of many of the patients in hospital. There is little time during the 4 days while they are there suffering from acute symptoms to absorb any information. And yet that's their most intense contact with the health system, right? It is while they are in hospital. Patients and caregivers are not in the right frame of mind to absorb information. They are both in shock. A quick note, by the way, in the U.S., we use the term caregiver. Your term here is carer. I'm not sure, because I'm working on another project with carers, I may slip back and forth, but they're unpaid carers when we talk about caregivers in this context. Patients report receiving information, but they're not able to process it. A stroke is largely going to impact their cognitive ability and brain functioning. They can't absorb the information. It may be there, but they can't absorb it. And they don't know what they don't know when they leave. That phrase came up in a number of the interviews that we did prior to even submitting the proposal. And on returning home, then, they can face many unexpected challenges. Oops, sorry about that. I think that is in the U.S., there's been a lot of work recently focusing on transitions. And transitions are clearly identified that it is a time of great vulnerability for many people across health conditions. It's not just a stroke situation. And in part it's because we have at least as much of a silo system in the U.S. as I'm hearing you have here in the U.K. in terms of the separation between health and social care services. And that transition then from hospital to whatever's coming next, they're often run by different providers. They're run by different systems with different funding mechanisms and different sources of funding. So that presents a problem. There have been several intervention models that show positive results, but there is still no clear best or standard practice that's been identified in the U.S. And a recent NICE report, and I know Annette and Jose Luis were both very much involved in that. We just saw that last week that just came out. Found little conclusive evidence for best practice. The report did present clinical guidelines for care, and they suggested areas for further research. Minimal research that we found in the literature, however, deals specifically with stroke patients in transition, and that was our target. That was absolutely our target. So our proposed solution in the proposal that we submitted in the project we're doing is basically to start with what seemed to be the core common element in many of the interventions that had been explored, and that was a coordinated case management program. Implemented, and there are, in the literature we find some are implemented by registered nurses, some are by social workers, some are by what are called community navigators who were trained paraprofessionals in our language, but they all had some type of coordinated case management program. In the Lansing area where Michigan State is based, we have a community-based care transitions program which followed the bridge model, which is one of the models in the U.S. that has had some traction. And we worked with them, talked with them, and decided to use a similar kind of model for our intervention. And there's a website here. If you Google bridge model long-term care, you will find an access to that link. What we did, and before I jump to the funder here, the biggest difference that we did in terms of what we found in the literature and even what our local CCTP was doing is that we added 30 days to the intervention. So most of the other intervention models had a 30-day time span. We upped that to 60 days for the RCT. And we also added an in-person component. Many of the other models depended on telephone follow-up. So in our intervention, there's an initial home visit, generally 7 days after discharge from the hospital, and then at least one other in-home visit, and depending upon the needs of the patient and caregiver, there can be additional home visits. So those two additional features were put into the model that we proposed. Sorry. Oh. Our funder, I just want to take a few minutes to talk about the funder because the funder truly drives the work of this project more so than any other funder that I've ever worked with before. It's a relatively new funding source in the U.S. It's called the Patient-Centered Outcomes Research Institute, or PCORI, P-C-O-R-I. PCORI.org is the website. It is, it was funded by the Affordable Care Act, which is known around the world as Obamacare. Yep. He had first resisted the name and then said, you know what? Here's my part of my legacy, right? Well, keep my name in it. But it was a part of the Affordable Care Act. So it's an independent, it's federally funded, but it is not connected or run by any other government institution. It's a totally separate funding stream, totally separate organization, which is focused on patient-centered care and shared decision-making. If you go to the website, you'll see a lot of information about what they are trying to fund, the projects that they have funded, what their values are. The biggest thing for us in preparing the proposal and now in carrying on the project is the absolutely central role of patients and caregivers throughout the process. They are involved in the review committee. We had to have data from patients and caregivers to justify even submitting the proposal. They're involved in making decisions about the intervention, making decisions about outcome measures. They are truly involved and integrated throughout the whole thing. So the overall goal of PCORI is to have greater involvement of patients and caregivers in common and important clinical decisions. This is the diagram that PCORI has proposed, and it's probably a little bit fuzzy, but it's basically a virtuous circle going from identifying and prioritizing critical issues for patients, getting them involved in the process of specifying what to try and how to design the research, conducting the research, and they're fully involved in the conduct of the research, disseminate and implement the findings, and then go back and evaluate the whole thing, and then redefine priorities. So it's not an unusual model in that sense, but it is in the role that patients and caregivers play throughout the process. We had never seen anything like it, and my colleagues and I have submitted proposals to many different agencies and foundations. This is the most extensive. I know you've got some similar kinds of things from some of the disability groups and illness groups. I just saw an email from the MS Society and talking about trying to get MS patients involved and survivors involved in that process. This is the first of any program that I've seen as big that has this much patient and caregiver involved. Any research that PCORI is going to fund has to address these 4 questions. And you've got to show in your proposal exactly how your research can help answer these questions. So given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options and what are the potential benefits and harms of those options? What can I do to improve the outcomes that are most important to me? And how can clinicians and the care delivery systems that they work in help me to make the best decisions about my health and my health care? So those are core patient-oriented questions at the core of the work. The funding announcement that we submitted to is one that talked about comparing the effectiveness of alternative features of healthcare systems, and particularly we were looking for, or they were looking for one that compared alternative models of care delivery. And so that's what we propose, comparative models of care delivery, and we need to emphasize comparing alternative approaches' effects on patients and caregivers in ways that they, the patients and caregivers, think are most important. And again, that message comes through. We felt we were being pounded. If you're submitting proposals, it's the constant message that you get. You make sure you've got patient and caregiver involvement. We were amazed that we were successful on the first round. We almost fell over. Yeah, and it was one of those, yay, we got the grant, and then, oh my God, we got the grant. Now we have to implement. Okay? Many of you have been there. 3-year, $1.5 million US beginning October of 2014. So the project has been up and running for over a year. First aim, stakeholder panels. So stakeholder groups must be fully involved in design, planning, implementation, and dissemination of results. That's a PCORI requirement, all right? So we've assembled 2 panels. We have recent stroke survivors and their caregivers, and part of the data I'll be reporting on are data from those panels. And then we also had a focus group of healthcare providers. We included nurses, therapists, social workers, just a whole range of folks. And basically we used that group to get a picture of usual care, since that was one of the conditions in the RCT. The goal was to identify, in particular, informational needs, preferences, and patient-oriented outcomes of stroke patients and their caregivers relevant to transitional care. Aim 2 was to incorporate the experiences, needs, and preferences of stroke survivors and caregivers into the design of the intervention. So again, we worked with the caregivers and patients that had been part of our database and our informants in the process of developing the proposal, and we worked through these questions and issues in the focus groups. And so we were talking about 2 different aspects of the intervention. One is a social work case management program that includes home visits and telephone follow-up over a 60-day period following return home, and it was based on that bridge model. I'm going to split occasionally between social work case manager and stroke case manager. It's the same, essentially the same group, or the same intervention. And then the other intervention that we proposed was a virtual stroke support portal, which is a patient-centered online communication, information, and support resource. It's a fancy website, okay, but it has informational support resources, communication resources. And in our original proposal, we said that we would develop this between months 6 and 12. As you'll hear later, that's wishful thinking, but anyway, that's part of the story. This was the design that we included in the proposal. So basically, and we'll get back to this again, but just to give you a quick sense of the kind of resources that we're in, we've got EHR, electronic health records. I'm not sure if hospitals in the UK routinely have those available. But in the US now, it's becoming pretty standard for hospitals to have an electronic health record, and I'll talk a little bit about that, but that was getting patients to access and caregivers to access the capacity that their hospitals were providing was part of what we had envisioned. Facilitated care team communication, so a safe and secure way to contact your physicians and other people on your care team. Medication information and medication adherence information. Stroke-related information. Care Pages is another application that's available online to help people set up a support group and have, it's sort of a, think about a Facebook page that you can have much more control over to share information with family and friends pretty easily. Social services, trying to think about that as community resources. In fact, we've changed the name. This is the original design. And then trying to link people up with other supports that might be in person but might be on the phone or online. So that was the original design for this portal. The third aim was to actually deliver the intervention. So we're going to test 2 complementary interventions against usual care, so 3 conditions, enrolling 480 acute stroke patients from 4 hospitals in Michigan. 2 of them are at, if you ever look at Michigan and see a state that looks like a mitt, Lansing is here in the center. Ann Arbor is about an hour southeast of us. And so they're both in the lower peninsula of Michigan. Those are the 2 areas, 2 hospitals in each area. 480 patients, so it's going to average 160 in each of the 3 conditions. Roughly, if we are successful, 40 from each hospital in each condition. That's the ideal. 3 parallel groups: usual care, social work case manager only, or the social work case manager plus this technology tool, this portal. Okay, and the intervention is supposed to start in January. I'll get back to that one. Trial inclusion criteria for, so that you have some sense of who this is targeted at. Okay, acute ischemic or hemorrhagic stroke, adult living at home prior to the stroke, so not being institutionalized prior to the stroke. Need to have stroke symptoms, NIH stroke scale, and I'm not sure if those of you that are in the medical field use a different stroke scale. Modified Rankin needs to be greater than 1. Discharged home, or if they're discharged to an intermediate care facility, that they would be going home within 4 weeks of that intermediate stop. We would not start the intervention with them until they went home after that intermediate facility. We would use a proxy respondent if the patient consent is not possible. So if the patient is aphasic or is cognitively impaired, we could get consent from the caregiver that had been designated and that the hospital knew about. Trial exclusion, we had to be a little bit pragmatic because there was a limited budget and we had limited money for travel and staff. So if they were more than 50 miles from the hospital, they would be excluded. And if we had some rural counties where people could literally be coming to the hospital but live 100, 150 miles away. And since we were doing home visits, that was not going to be practical. If they were discharged to hospice care, nursing home for long-term care, or a long-term care hospital, no proxy respondent available, or if they failed the cognitive screening and there was no proxy respondent available. If they were enrolled in another acute stroke intervention trial, and there are many of them floating around, we've got a lot of hospitals in the area that have studies ongoing. We just did not want to be cross-contaminating other studies and our studies. So if they were in another study, they would be excluded. Limited life expectancy, so if it was less than 6 months, or if there was significant comorbidity, they would be excluded. And if they would be excluded if they did not speak English. In mid-Michigan, that's going to be a very small number of patients that would be excluded because of language. Primarily English. There's a small, I want to say maybe 10% at most of the population would be Spanish only, and maybe under 5% would be Arabic only in the counties where we're working, but very small percentage. Caregiver eligibility, any person identified by the stroke patient as the primary caregiver, and they were that was an individual primarily responsible for assisting with the patient's care. We just operationalized it very simply. The patient would have had to consent to have the caregiver involved, and it would only be for adults. And the exclusion criteria, again, that the caregiver, if the caregiver did not speak English, they would be excluded. Okay, let's turn now to the first phase of the data collection. We moved last April into the first of the focus groups, and we ran 4 focus groups with patients, patients and caregivers, and they were both in the same focus group together. We did 2 in the Lansing area, 2 in the Ann Arbor area. These were the themes that emerged from those focus groups. These were hour-and-a-half focus groups. They were transcribed, and we had multiple people taking notes, pull the data together, and then did a thematic analysis to pull out the main themes. These were what patients and caregivers said. Unprepared to discharge home, trying to understand medication is something that they really felt a need to learn about. They were concerned about stroke reoccurrence. There were questions about what caused my initial stroke and how do I prevent a second stroke. So the etiology, and the practical steps, what can I do? Caregiver stress, and the need to access reliable information. Everybody knew there was a ton of stuff out there. Getting reliable information was a bit more of a problem. What we then did was, and we took the information that had been provided at the first focus group, and at the start of the second group did a quick instrument construction during a break in the second group, and then essentially took the themes and asked people to rate the importance of each of those major themes that had emerged. And what you've got here in blue is very important, the red is somewhat important, the green is not important. And across the bottom, what you've got are the themes that I just mentioned in the previous slide. So we've got unprepared for discharge, understanding meds, stroke reoccurrence, stroke prevention. These are the 2 that showed up the most. caregiver stress, and reliable information going across. These are the patient ratings using a simple, very important, somewhat important, not important scale. Trying to keep it simple so that we can get reliable data from people who are still, I mean, these folks are still talking in the focus groups about they still have symptoms, they still have challenges in their life. They were interested enough to come to these focus groups. The caregiver picture is very similar. So again, this is caregiver assessments of these same 6 themes in terms of very important, somewhat important, not important. Stroke reoccurrence and stroke prevention, and then understanding medication showed up a little bit more frequently and was rated more important by the caregivers than by the patients. But they're all, none of them is something that people discuss. They had identified the themes. We were just trying to get a sense of the relative importance from our participants and wanted to report that information to the court. I mean, this is part of why we developed the website the way that we did. We then talked to the patients and caregivers about how do you think we should be measuring a successful intervention. It's not just what measures did we think were important, but for the caregivers and for the patients, what measures did they want to identify as things important to follow, to include. And so we identified these as a starting point. If there were a bunch of measures, and they identified these as the ones to look at, and then we had them rate, as you'll see in a moment, we had them rate which ones were more important among the measures, the outcome variables, if you will, that would be important. Satisfaction with care after return home, quality of life, stress, ability to look after your own affairs, ability to return to work and normal activities, improved knowledge about stroke and stroke prevention, physical function, and mental function. All of these were items that they identified as potentially meaningful outcome variables for them that they essentially said, make sure you include in your measurement. Okay? So again, with the approach that the Corey takes, we had to take that as our real message. That was our starting point. We then asked the patients to identify how important these indicators were to them, to look at the relative rankings across these. And so this is the patient data. Again, blue is very important, red is somewhat important, and the green is not important. There are a lot of things that people identified as pretty important, right? What we thought was kind of interesting is that the satisfaction with the care after people got home was less important than some of the others. It was just we just thought that was a little interesting. Quality of life, mental function, physical function, and the ability to look after their own affairs were the ones that scored the highest. Now, these are small samples. We recognize that. These were just the folks that came and participated in our focus groups, so they are small samples, but it still gives us a sense of what might be important to the kinds of folks that would be in the study, and that was the whole point. Caregivers rated them a little bit less important, but again, most of them scored 60% of the caregivers, saying that these are very important things to measure. There were very few that were picked as only somewhat or not important. So we thought at least we were on the right track in terms of identifying a cluster of variables for which we need to have good measures. And that then became our job. The trial outcomes then were informed by these focus groups. They're being measured by telephone at 7 days and at 90 days. We would love to have had the resources in the project to do face-to-face data collection with all of these folks. We just simply did not have the money in the budget. So we are depending on telephone. And it's going to be, there's a group on campus that does computer-assisted telephone interviewing all the time. We are working with them now. We are piloting the surveys right now. It's going to include, and again, trying to feed off the types of things that the patients and caregivers told us. So we've got the patient activation measure. I thought it was fascinating yesterday to attend a session where there were so many other quality of life instruments measured, and we're using one that was not on that list yesterday. So for those of you that are QOL experts and interested, the PROMIS, without an E, the PROMIS Global 10 is part of a set of instruments developed by the National Institutes of Health, and they are publicly available. They are used fairly extensively in health-related studies in the U.S., and our experts that are the measurement experts picked that one as the best one to use. It is a 10-item measure. There were also some other promise scales that were included here. So we've got the promise QOL self-efficacy scale, the promise QOL support measures, and there's an anxiety measure. And we also have measures of time at home, stroke knowledge, hospital or emergency department visits, and stroke reoccurrence. Those are the primary and secondary patient outcomes. We also have a number of other measures that are included. So we've got demographics that are collected at the hospital site. We've got information about the stroke itself. We've got the Bartel Index, some neuro quality of life measures, and then because there is a technology component here, we had to have a couple of measures of technology, attitude, and aptitude, and utilization going into the study. And so we're going to have that as part of the baseline for everyone. Since my interest is in the tech tool, that's part of the cluster of instruments that I was fighting for. Caregiver strain index, preparedness for caregiving, mood, stroke knowledge, satisfaction, and dyadic relationship are all of the measures for the caregivers that are being collected at 7-day and at 90-day. We also, and I was just looking through the latest thing, we do have the caregiver perception of the patient QOL. We were talking about that yesterday at 90 days. That is going to be in there as well. So there's an interesting sub-study down the road. So, okay, let's see here. All right, so let's get back to, so we talked a little bit about the measures. Let's talk about the two interventions. This, again, is the same slide that I showed you before. This is our original conception of what the intervention was going to look like, the technology tool was going to look like. We asked the participants in the focus groups to tell us, well, what do you think you'd actually use? Novel idea, right? We had this great vision of what we were going to offer to them. Surely it was going to be a useful tool. What would they actually use? And so we asked in the focus groups, both patients and caregivers, to identify which of the items that were in. And starting with electronic health record, this is the email system, this is medication information, stroke-related information, links to local social services, stroke support groups, caregiver pages, and then finally video tutorial. Which ones did they think people say they would actually use? Okay, or think they would use, right? The two that showed up the most for patients were stroke-related information and medication information. Clearly, we were getting the message that we should spend a lot of time on the information resources. Remember, we thought about this as information, communication, and connectedness and support tools. What they were saying was most important was information. That's what they wanted. They wanted good, reliable, easy to access information. The caregiver data is very similar. Again, here's the medication information. There's the stroke-related information. Those are the two top ones. And they identified more than the patients did the stroke support group. Not surprisingly, they were looking for peer support, or saying that they thought they would use that aspect of the website more than the patients said that they would use it. Okay. The other one, the caregivers identified fairly strongly was the electronic health record. They thought that that might be a useful tool. All right, so part of our problem in developing the portal gets to, and those of you that are worked with stroke patients, what are some of the challenges? And this fits with people with dementia. It fits with people with cognitive impairments. These are, and older adults in general. The literature on older adults and technology is quite similar here. Cognitive challenges. People talk about brain fog. They talk about having difficulty retaining any kind of information. So if you're showing them how to log into a site, they're not going to remember it as readily as we hope the folks in this room will. Okay? Physical challenges. Simply manipulating the tools is another area. Skeptical attitudes. Why should I waste my time learning how to use this thing? I don't think the web has anything of value for me anyway. Privacy and security concerns. Just because you think you're paranoid doesn't mean that your data won't be hacked, right? That's one we all face. Okay? It is not just for our patients. That's an everyday international phenomenon now. So, and when you're dealing with people who are somewhat frail and vulnerable to begin with, it becomes a major concern that we have to address. And then finally, difficulties learning new technology without help. So there's a fairly broad literature across illness groups, disability groups, and age groups, especially for older adults, that these are primary issues that need to be addressed for anyone thinking of developing a technology tool to support them. All right, so let me take a second and show you, very briefly, if I can make this work. This is the current version of the website. What we tried to do, we started with and put kind of front and center stroke information and medication information, as these were the areas that patients and caregivers said that they were most interested in pursuing. And so when you go to the page, and this is a work in progress, okay? We still have another month to kind of get this thing in the final shape, and I'm going to give you some information about the feedback that we've gotten thus far. But I just wanted to show you this is the way it's starting out. So, and then as you click through here, and I'm just going to take a minute to show you. So in stroke information, you've got specific content related to what is stroke, types of stroke, signs and symptoms, how do you respond, stroke diagnosis, emergency treatments, why did I have a stroke, risk factors, stroke prevention, stroke recovery, stroke rehab. That range of topics related to stroke that people wanted to find information about. Can they get it elsewhere? Yes. You can contact Dr. Google and you'll get tons of information. Part of the message that we're trying to convey is that we've taken a step of refining it and made it a little bit easier for you to access and hopefully to read and put it all in one place. That's sort of the message. And if you think about the intervention, and I'll go back to this point later, the biggest thing that we've got going for us is that it's going to be presented to the patients and caregivers in that third condition by the stroke case manager at the time of the home visit. So that they're going to have a human person to show them how to use the site, to talk about the value, to hopefully increase utilization of the site. That's the whole purpose of the intervention. And so we've got some videos where we've taken, all right, I'll just, while I'm talking, I can do this. We've basically shown them, all right, so there is in Michigan, there's a 211 site, and like if those of you in the US, 411 is the number we used to call for directory assistance. 211 is a nationally mandated phone number that can only be used for social services information, social care information. So it's run by United Ways and other NGOs, and they basically have a 24-hour telephone service. They also have a website available so that if you're in a particular area, you tell them what county you're in, and they will help you identify home respite care. They will help you identify funding to help pay for medications. So it's a whole range of information that's available from this 211 site. A lot of people don't know about it, and clearly for folks who are not able to use the computer, they know we're trying to tell them, just pick up the phone and dial 211. 24/7, it's available. It's a phenomenally useful resource. It's not loading, and I don't want to take any more time on it, but what we're going to have here are some short videos basically showing people how to access the site online. So it's just basically a voice-over clicking through the 211 website showing you how to get information about a particular service that you might be interested in. All right. Okay, so let's get back to this if I can. Okay. So that was the current site. It's not accessible to the public yet, and you will need, during the course of the intervention, it's only going to be available to people in the third group who have a username and password. So if you go to the site, you're not going to be able to get in, but you will be able to see that cover page, just to get a sense of what's there. Another important part of the development in getting feedback from patients and caregivers was the usability assessment that we just finished. And so these are issues that were identified by having a group of, let's say, 9 or 10 patients and caregivers actually try to use the site. They identified some issues that needed to be needed to be fixed. Content had to be simplified, or has to be. Navigation has to be made simpler. We need to improve the search function. We need to make sure that people know when they're going to an external link. And we need to refine navigation tools. It's a work in progress. We are working on making these corrections. Let's see. All right, let me do quickly through, since we're running short on time. The case management intervention, if you're not familiar with case management, basically it is a fairly broad, it's not a clinical intervention, it's more of a, think of it as kind of organized and guided problem solving. I think that's perhaps the best way to think about it. And social workers are trained to do this. This is one of the things that they have expertise in. So these are essentially the steps in that case management intervention that people in Group 2 and Group 3 will receive in the RCT. So engagement, first meeting the patient, assessing what their needs are, and so there is a very extensive needs assessment document or survey that's done in person with the patient to try to identify what areas do they need help with. Are they having trouble paying the rent? Are they having trouble getting their medications? Are they having trouble getting to the doctor? Trying to identify all of the needs across a whole range of everyday life. And then helping them plan how to address those needs. So it's a proactive, driven by the patient and caregiver. And I think that's the main thing. It's not driven by what the professional thinks has to happen. We've got the set of questions we ask. They identify the areas to follow up on, and then our job as case managers is to follow up with them. We'll make referrals. We'll make sure they get to the referral. We'll make sure that the agency with whom they've contact does what it's supposed to do. So it's a very active and proactive type of intervention. We'll do some patient caregiver education. There's some short-term problem solving. It's not a long-term clinical. This is not a counseling situation. It is not addressed at mental health issues. It's much more practical, pragmatic, dealing with the issues of everyday life. And then we'll be monitoring, following up. We need to terminate at 60 days and then refer them to whatever resources we can find for them in the community and document everything for the research. Now, the same people are delivering both the case management intervention in Groups 2 and 3 and the technology tool in Group 3. So methodologically, in terms of the interventions, we have to be very careful about how the same staff handle technology with Group 2. That's a major concern. You want to have the same people for all of those non-measurable kinds of personality, idiosyncratic dimensions of the two interventions, but you got to be careful that they don't do too much. And so we basically tried to operationalize the distinction by saying in Group 2, in the stroke case management only condition, they talk about technology only if and when it is initiated by the patient or the caregiver. So if the patient or caregiver says, is there information online that I can get in addition to the paper brochures that you just handed to me, they're not going to deny it. It's unethical for them in their practice to not answer the question. They will say, yes, you can go to the American Stroke Association and get some information there. And if they ask, can you help me do that, they may help them get in the first time. But that's going to be the extent of it. Similarly, if a patient or caregiver says at the hospital, they mention that there is a patient portal, can you help us sign up for that? We will. All right, the case manager will do that, but it's going to be a one-time only. We're not going to give them the how-to resources. They would then have to follow up on their own. And that's how we try to operationalize the distinction between Groups 2 and 3 about technology. We've also got the baseline, and we'll have 90-day indicators of technology knowledge and use from patients and caregivers in all of the groups. And we'll be able to, and we will intend to ask them, where else did you go to get information during the course of the intervention? So we'll find out if any Group 2 patients or caregivers are spending a lot of time online doing the same kinds of things that we put into the website. In any case, in group 2, there is never mention made of the website. At the end of the project, everyone will get access to the website, but it's not supposed to happen sooner than that. Okay, tech lessons learned already. It's amazing what the difference, and many of you have done this, what's the difference between what we think we'll be able to do and what we can actually do? Okay, so we have already learned that adequate resources are needed. We did not build in enough time or enough money to develop the tool that we're trying to test. We know that now. They take more time and they cost more than you think they're going to. Interesting conversations with other PCORI-funded projects, and in the literature you're going to see tools that have been developed that look like such great tools for people to use to help with their health issues that are never adopted because of all kinds of reasons. But it's a tougher job than you think it's going to be. So we're learning. You need to locate the right experts. Not every university. I've got a huge university with a lot of different departments. Not every university has the special talents and skills that you need to develop some of these technology tools. In particular, we're discovering that we need better website developers in the health field. I think if we had to do Blue Oval, we would contract that out. And you need good health communicators. And we're finding more and more that our message, the content, people want that information, but it's the language needs simplification. It needs really to make it more easily accessible cognitively, if you will, for the users. And then the third one is one that we're kind of telling ourselves now every day. Don't let the perfect become the enemy of the good. We keep trying to get it as best we can, and we're going to have to let go of it at some point and say, this is going to have to go. And we will fine-tune if we need to, if problems arise, and if a link changes, we're going to have to do that kind of thing. But essentially, when we're ready to go, it's going to have to go. And we don't want to stress so much over making it perfect that it delays things. We're also finding, I mean, again, the literature is full of things like great interventions that were designed well that seem to be perfect that are getting uptake of maybe 15% in terms of people actually using them. These are in health interventions that are technology-based. And that's a scary figure, 15%. We're hoping that the in-person contact, and that was one of the issues or one of the themes that drove the preparation of the proposal, high tech and high touch. Those stroke case managers are going to be there to help initiate people in using the site and hopefully to encourage their use. So our next step, immediate priorities, we still have some institutional review board or ethics issues to deal with. We've got 2 of the hospitals, so we have 2 more to finalize. We need to finalize the web page. Our pilot phase is going on right now, so we have begun recruiting people for the pilot phase in the Lansing area, so we're getting information about how everything is working, everything from the data collection, the recruiting, the data collection, and the actual intervention. And we launch in January. That's the plan, so that's coming up pretty soon. And the rest, I can flip through these while I start taking questions, because essentially these are the tons of other people that are involved in the project. So it's literally a cast of many, many people and different organizations. And at that, this is an acknowledgement from our funders. This is the funding source and a disclaimer that these are my opinions and not theirs. And I'll take questions.
Over to you. Questions, comments?
Yes. I gather that survivors of strokes are a hugely sort of varied group, and I've seen that with people I know. Some have recovered a lot of abilities, some haven't. Did you find that a challenge for this study, that maybe the people with different conditions and circumstances feel differently about different possibilities?
And absolutely, and that's one of the things we plan to measure. Is really, I mean, that's why we tried. As you know, it helps to have big numbers. With 480 people, we're going to have a huge variety across the study and in all 3 conditions. And so we really are hoping to be able to address some of the issues around how severity, how recovery impacts how they use the technology, how they're taking advantage of the case management intervention. I think we're going to put in for funding to do right now we're going to do data collection at 7 days and 90 days. I think we'd like to do data collection even later than that and look for funding down the road to see if, in fact, as people recover, will they use the tools more? Yeah.
Can I ask about some questions about the generalizability of what you're expecting? So, is your baseline comparable to the baseline in other states in the United States? So that's one question. And the other is you've created a system change with a product, in effect. So does Michigan State own a product, or does your funders own the product that you've created? I'm just intrigued by that.
Yeah, I think it's a good question. I don't think we have the answer to that. I don't think the funder owns the product. They are not into doing that. Our university says if we created it on university time, they own it with us. We're not sure how marketable it would be in the form that we're developing it, but the notion of putting together a range of resources to make it easy for people to access. Essentially, this is going to be a proof of concept. And if, in fact, it seems to work and we can identify the variables that are tied to greater utilization, we'll probably run with trying to develop it further and look for an outside company to work with. The university is not at all adverse to taking entrepreneurial ventures. In fact, the major part of our internal university funding comes from a drug that was developed maybe 15 years ago that huge revenues come from that. So yeah, they will try to get us to market it if there's something marketable there. Other questions?
I wondered about your 4-day average for length of stay.
Yeah.
In this country, particularly in London, you now have specialist centres where patients go direct for immediate treatment, as you probably must know. But then they go to the sort of local hospital nearer their home. I wondered if you could form sort of, ongoing care for a while in order for them to then have the community care in place before they go home.
Right.
I wondered how that compared with...
In the U.S., the 4 hospitals that are in the study are pretty much the regional medical centers. These are in the Lansing area. If you're going to go to any hospital for regular hospital treatment, it's going to be one of those 2. In the Ann Arbor area, it's one of those 2. So these are general kind of regional hospitals. If 50% of the people who have strokes in those 4 hospitals go home directly without intermediate care, 25% go to one of these intermediate rehab facilities or skilled nursing facility, depends on the severity of their condition. And we'll still take them in the study if that's not going to be more than 28 days. If they're going to go home after 28 days, we'll still take them. But there isn't the same kind of specialized stroke hospital or stroke center that I hear you asking about.
Just to follow that up, because recent results, it's only, I think the model was implemented, say, between 5 and possibly 10 years ago, but fairly recent, I think. And it's been found very effective. Of course, the patients, receive immediate care with anticoagulating therapy if necessary, or the other way, if not, depending on the type of stroke. So if your patient's going, it's not related particularly to your study, because you're looking at patients after that acute episode. It would be quite interesting because they're being admitted to a general hospital really without perhaps that specialist care.
They have, within each of the hospitals, there is a stroke ward. And that's where we're actually recruiting them. There's a stroke team and a stroke nurse that's designated. And so I know at Sparrow, if you come in with a stroke, you're going to wind up on floor 5 in this wing, and the staff are specially trained to deal with strokes. So they're sort of building that concept into the general hospital. Yeah.
Great presentation. We have already some trials ongoing in interventional patients and cardiovascular care, looking at quality of life measurements in a 2-year follow-up.
Yeah.
And these old patients were very elderly patients, and it was quite hard to get quality of life measurements by telephone follow-ups. So I really have some concerns about these complex questionnaires you mentioned here. to measure life quality. And therefore, my question is, have you trained your staff to do these questionnaires? Have you seen from the first follow-ups maybe some problems doing these questionnaires? And how have you calculated your numbers in the different groups to get really valid data at the end, because the variation will be huge?
Yeah. A couple of parts to the question. We have trained them. They are now literally trying the first sets of interviews by phone. I'll be able to answer your question better in about 2 months. But we realize that that's one of the things we have to investigate. And we may find that we're going to have to do a major redesign and do some face-to-face data collection. That is possible. If we come to that, we're going to have to go back for additional funding or reduce our numbers, and that has other risks. You get the numbers too small. Part of the reason for 160 in each condition is that we thought that would allow adequate numbers to cover that range. So we're hoping with that large sample in each of the conditions that we'll have adequate power to really analyze the data. I did not do the statistical calculations to get to 160 in each condition, but we did a lot of power analyses based on whatever data we could find about effect sizes to come up with numbers that look reasonable. So another big challenge is recruiting 480 people for this study. And that again, we're going to find out from the pilot if that's in fact feasible. Yeah.
Really great presentation. In Ireland, we're doing similar work with heart failure and the discharge management post diagnosis of heart failure. And the product, the website is very good. But BTHF was a paper published there in AHA, and they reviewed the management of the patients who used a similar intervention. They found there wasn't very much uptake or continuation in use. Perhaps that, and it was a negative result, there was neutral findings. Perhaps though that tainted the results, that people who didn't use it at all, who were offered it. So in your selection criteria, would, if you picked only those patients that say already use the internet twice a week as part of your selection criteria, and then randomized from there, would that be?
Then it becomes less generalizable. I mean, part of the reality is if you're talking about stroke patients, a lot of them are going to be over 50. So in the U.S., there's maybe 60% of people over age 50 use the internet, and then you get a biased sample that way. We're hoping that by going this route, we've got a more generalizable sample. And if in fact through that, I mean, part of the theory behind this is that the home-based and the human contact of the stroke case manager may improve the uptake of the technology tool. And so it's not just the technology tool, it's the technology tool with that human intervention to try and encourage that. That's really what we're testing. And if it turns out that those people, in fact, a broad range of them do use the tool, then we've got support for continuing that design. So that's why we did not just pick people who were using.
I'm going to take two quick questions, and one here, Margaret, and then we have to stop.
Okay? Yeah.
I see the point that you made about being pragmatic about inclusion criteria and restricting the analysis to patients living quite close to the hospital.
Well, 50 miles.
Well, I would assume that probably one population of patients that would benefit the most from such intervention would be patients that live much far away, actually. So would you extend or apply the results of the study to patients that are supposed to come from more rural areas?
Yeah. In Michigan, the rural areas are, if you go 50 miles outside of Lansing, you're still fairly rural.
In Michigan,
Yeah.
third person here.
Yeah, oh, you're yeah. All right, so you know. Yeah, I mean, when you go 50 miles outside of Lansing, you're already pretty rural.
Okay.
So we think it will generalize to the larger group. We just had to be very pragmatic about it. Yeah. And again, that's a great question to follow up, though. And if it works in our areas, then we'd like to try it statewide as the next step. Margaret?
It's one of the comments you made. I was just thinking you're talking about anybody 18 upwards, so therefore you'd expect that the younger population is going to have much more familiarity with using the internet and the digital processes. So
But the incidence of stroke that early is lower. Yeah. We did have some young onset stroke. We had in the focus group we had one gentleman who was maybe 32. Yeah. But as a percentage would be lower. Thank you.
Okay, I'm going to stop there. Thank you very much to everybody for coming. Thank you very much.